Thank you so much, Partha, for once again having me in a wonderful course. It's always a pleasure to join in. And my topic is indigenous phakic intraocular lenses, my experience. And these are my financial disclosures that I do speak for Star, IOCare, and Biotech. And when you speak for all these companies, that means you don't have any financial interest. And basically, I think it's extremely important we understand the concept of correction of high refractive errors. This is a study from Australia published almost 15 years back, in the sense that beyond minus 10 diopters, it's only 2% of the population. But at the same time, 13% of them constitute the patients who come for a refractive surgical procedure. It is likely that moderate myopes, that is minus 5 to 10 diopters, are more likely to come for a refractive procedure, while high myopes beyond minus 10 diopters are 16 times more likely to present for a refractive surgery. It's intuitive and just stands to reason, because these are the patients who are most bothered by refractive error, and these are the people who are going to be most benefited by getting a refractive surgical procedure done. And imagine a youngster like this, he's a 31-year-old man, and whether it's a high myope or a high hyperope, it's not that it's just refractive surgery is a cosmetic procedure. I don't even consider LASIK a cosmetic procedure. I think it's a life-changing procedure which improves the quality of life for a patient. And as surgeons of third millennium, or as ophthalmologists of the current day, we owe it to our patients to get precise ways and means to get rid of these extremes of refractive error, because it does impact their life in various ways, irrespective of what they do. But I started with ICLs almost more a dozen years back, was extremely comfortable with that, and stayed on with that. But at the same time, cost was definitely an issue. The reason we had our own reservations about shifting on to something different was that these are patients who come for this refractive surgery or in the prime of their productive life, and they need glasses, which is definitely disabling, but it's not something, not as if they do not have vision. And you don't want to do a procedure with which they have to live for maybe next the 5, 6, 7 decades, and which might have an impact on their eyes. And that's the reason it took us some time to adapt to these alternative lenses. And today we have several platforms that are available in India itself. I'm told that Appasamy also has a reasonably good lens. My personal experience has been most with ICL and then with IPCL, and now recently I've tried a few ICRIL lenses. So just to give you a snapshot of the differences between these lenses, basically the ICL is available from plus 10 to minus 18. The IPCL comes in a much wider range of plus 15 to minus 30. ICRIL is minus 3 to minus 23 diopters. Astigmatism correction, a much greater amount of astigmatism can be corrected with the IPCL. As far as the material is concerned, the ICL is made up of collamer material, which is supposed to be the most friendly as far as the intraocular milieu is concerned. While these two other lenses are made up of the hydrophilic acrylic, more akin to the material that's used in the intraocular lenses. Whether this is most suited as far as placement in the sulcus is concerned, that's somewhat questionable. But having said that, I've been implanting these lenses for about last 3 to 4 years, and there doesn't seem to be any adverse reaction. So maybe this is one slight concern we might have, but then time has shown that hydrophilic material is also quite biocompatible in the intraocular milieu. And as far as the openings are concerned, now all these lenses come with a central hole, because of which a PI has become redundant, and there are 2 paracentral holes in the paraoptic region in the ICL. And most important difference that you must understand is that in the ICL is a leading right and the trailing left, which has these small marks over here. And in the case of an IPCL, it is essentially, it has holes in all the 4 haptics, and there is a small, that stud is not shown here, is a slightly old picture. In the leading left and the leading trailing right, you have a small stud over here, and that tells you what is the orientation of the lens. In the ICRIL, it's again in the leading left and the trailing right. So essentially, when you're if you're used to ICL and if you're shifting over to any of these lenses or trying out any of these lenses, you must remember that the orientation of these lenses is slightly changes. Because of the holes in these lenses, there's no PI that's necessary. Both these ICL and ICRIL come with 4 pads These are the pads which support. Well, IPCL is has 6 pads, and the manufacturers claim that it adds to the stability of this lens. And when it comes to well, ICL, the EVO platform, when it's toric orientation, most often you have to dial the lens into place, but in IPCL it's customized in the sense that each and every lens you can just place it inside and leave it at 0, 180 degrees, because each lens is manufactured accordingly. To my mind, that's a great advantage as far as the toric IPCLs are concerned. ICRIL, on the other hand, has markings at every 30 degrees, so that more than 5 degrees or so of rotation is not necessary. As far as the central holes is concerned, is 360 micron, 400 micron, 360 micron. Various bench studies have shown that if you have a hole in the center of 360 microns, that does not interfere with the quality of vision as far as the patient's visual acuity is concerned. And I already mentioned about this hole in the haptic, and all 4 haptics has holes in the IPCL, and this is said to be an advantage in the sense this allows the lens to adjust even if there's a slightly higher overall diameter lens that has been placed. Because of this these holes in the lenses, it's said that it can adjust to the dimensions of the sulcus. And the ICL is dispensed in BSS, while these 2 lenses are dispensed in saline, because as Partha was already mentioning, because of the being dispensed in BSS, these lenses do not expand, while the other 2 lenses which are dispensed in saline tend to expand a little bit, and maybe the final vault of the lens is what they have after 24 to 48 hours. Loading is somewhat different with the ICLs, but with the other 2 lenses, if you are used to plate haptic lenses, intraocular lenses, it's no different. And again, sizing of the lenses is more confined in ICL, and in IPCL, and especially, you can get even made-to-order lenses of higher optics, depending upon the requirement of that particular eye. Now, I'll just show you a brief video of the IPCL being implanted. Because it's a hydrophilic acrylic material, it comes dispensed in saline, and you can see the lens being, this is a cartridge very similar to what we use for other plate haptic intraocular lenses. So it's extremely easy to adapt, and I'm not using the Varion here. You can see the markings over there. I like to have about a 3 millimeter, that's a 2.4 millimeter diamond knife, so slight extension on the side, and then stabilizing the eyeball using a spatula, and subsequently injecting the intraocular lens, making sure that the leading left haptic is the hole is in the leading left haptic, and subsequently you always inject it into the anterior chamber in front of the iris, then gently tuck the haptics behind the pupillary margin. And once you have done that, never try to inject it directly behind the pupil, and then finally you orient the lens to come across with the 0, 180 degrees. As I said, with these lenses, there's really not much of rotation that's needed. As far as the ICRIL lenses are concerned, I have limited experience. I've just used it for about 5 or 6 of them in the last couple of months. But these lenses also seem to be working reasonably well, and almost very similar to the IPCL platform, and maybe slightly thicker. And as you can see, this lens is also injected inside, and you can see that the markings over here are not in the 0, 180 degrees, but it's the 90 degrees. And here they change the markings to every 30 degrees, depending upon the kind of toricity that you want to induce. And the manufacturers claim the advantage of this is that you don't have to rotate the lens by more than 5 degrees. So I think these are the variations that we have. We ourselves have done a study with the IPCL, which has got published in Clinical Ophthalmology, and I will just give you a snapshot of what we did. Basically, it was to evaluate the efficacy of indigenous posterior chamber phakic IPCL, and the period of study was for 3 years. Toric IPCL was 134, and 35 as non-toric. Hyperopic eyes, we just had 2 eyes, and as you can see, myopia is the greatest indication. As was being asked, keratoconus, we had 21 eyes which were after stabilization, and central cones we implanted in 21 eyes, and then subsequently the range of sphere that was treated was up to minus 21 diopters, cylinder was up to minus 6 diopters, spherical equivalent was up to 23.25. This is significantly a higher amount of refractive error than what's possible to treat with the conventional ICL, and the extremely gratifying results that at the end of 6 months, the residual error, both the sphere and cylinder, as you can see, was extremely small. And the number of eyes change in lights compared to preoperative best corrected to postoperative uncorrected visual acuity at 6 months, which indicates the efficiency of the platform, is that 67, almost 7, 4, 8, almost 90, 84% of them had better vision than what they had preoperatively. 16%, because of slightly residual error, did have a drop in a line of visual acuity. 4 of these eyes underwent bioptics procedure, and some of these eyes patients decided to stay with the refractive error simply because they had extremely high refractive errors to start with. And preoperative best corrected visual acuity to postoperative best corrected visual acuity at 6 months, which is essentially indicator of the safety of the device. Only one eye did lose a single line of vision. In all other eyes, there was either maintenance or improvement. Improvement is something that you expect in this because the minification effect of the concave lenses goes away, and there is a certain amount of improvement in visual acuity. As far as complications are concerned, fairly minimal, raised IOP in 3 eyes which could be medically managed, shallow AC, high vault, AC reaction, decentration, which has to be repositioned in a single eye. Keratoconus, interestingly, 15 eyes gained a line of vision, and 3 eyes, 15 eyes maintained the kind of preoperative vision that they had, and 3 eyes essentially had an improvement in visual acuity by 1 line. To conclude, implantation of indigenous phakic intraocular lens is a safe and effective procedure for refractive correction in myopia, hyperopia, and astigmatism, and in stabilized centered keratoconus patients. I think it's important that we have this facility available to us even in these extremes of refractive error. Thank you so much.